So today we'll be talking about malaria. This is a quick revision of malaria except the time which takes me to write. So first, just going over the basics. There are two great men who were awarded Nobel Prize for malaria. So that is Ronald Ross and Alfonso Lavrin. He found out the causative organism for the malaria, Ronald Ross, and Alfonso Lavrin found out the vector. So basically, malaria is a parasitic disease, which is the Plasmodium parasite. So there are different species of Plasmodium. We have Vivax, falciparum, Malariae, ovale malaria, and the recent found Knowlesi. So these three cause something known as tertian malaria. This is quatern malaria, and this is quaternion malaria. So this is a parasitic disease and it is a vector-borne disease. So vector is a infected female Anopheles mosquito. There are again two species, Stephensi and Calcuficens, for the vector. Now, how does the transmission occur? So transmission occurs through three routes. Either there is a bite of the vector, or there is vertical transmission from mother to child, or there is through blood transfusion, which is rare. Coming to the life cycle of the parasite, how this works. So basically, the salivary glands of the mosquito has sporozoids. This mosquito now will bite a human, and it will lead to these sporozoids entering into the circulation. Now these parasites, they quickly enter the hepatic circulation and enter the hepatocytes to bypass any immune obstruction, or cause any immune stimulation. They quickly enter the hepatocytes. Wherein they transform into trophozoites, then merozoites, which are basically the hepatic schizont. From there, they will leave the hepatic circulation, hepatocytes, and enter into the circulation again, wherein they enter the RBC. After entering the RBC, they form the erythrocytic schizont, and from there they come out. But here one thing happens is there is rupture of RBC. So rupture of RBC occurs and two things come out. One is this erythrocytic schizont, and the toxin comes out. This toxin causes fever, and we'll see in clinical features later on. This erythrocytic schizont again develops into gametocyte. There is micro and macro. So macro is the female gamete, this is the male gamete. Both these will now again be in the peripheral circulation, and again mosquito bite will happen, which will cause these to enter into the mosquito. They fuse to form a zygote. From the gut of the mosquito, they again traverse and reach the salivary gland, wherein after the fusion, the zygote or the ookinete, they transform into sporozoites again in the salivary gland. So this is how the cycle goes. So basically there are two parts of the cycle, where is the man and the mosquito. This is where the sexual cycle takes place. This is where the asexual cycle takes place. Now coming to the presentation of the person, like the clinical presentation. So we can say basically we can divide it into benign presentation or a malignant presentation. Talking about the benign first, it basically causes febrile paroxysms wherein there is fever which is episodic in nature. It is high fever. We'll talk about it. So there are three stages. There is cold stage, there is hot stage, and there is then sweating stage. So cold stage is before the fevers, 1 to 2 hours before the fevers, wherein the patient will have malaise, headache, lethargy. Thereon, the fever will start occurring. It is very high fever with chills and rigors, and headache. At this time, there will be no sweating. The skin will be hot and dry. After which the fever comes down by sweating. Profuse sweating will be there. Patient will feel a bit of relief, but still the fatigue and tiredness will be there. Here the skin will be dry and cold. Wet and cold. So this is febrile paroxysm. As we saw here, Vivax, falciparum and ovale, tertian fever. So every 3 days the fever occurs. Malaria, cotorrhea, every 4 days the fever occurs. Knowlesi, this is quaternion, every day the fever occurs. So this fever is correlating when this toxin is released from the RBC. So certain other features about the parasite. So we have Vivax, falciparum, ovale, malaria and Knowlesi. So all this depends on when the toxin is coming and when the fever is happening. That depends on the time of the life cycle. So here it's 48 hours. This is 50 hours, this is 72 hours, and this is 24 hours. That's why everyday fever every 4 days. This is approx every 3 days fever is occurring. And they have preferential liking. They have a liking towards which RBC to affect. So Vivax affects old RBCs, and this affects new RBCs. That is why this is also very fatal and very bad prognosis. Falciparum. This ovale reticuloendothelial cells are affected, and RBCs up to 20 days old is affected. Here reticuloendothelial cells is affected. Now coming to, we have went over the pathology. Now we can just divide malaria again into uncomplicated and complicated. So uncomplicated is when there is fever with chills and rigors. There's tachycardia, there's tachypnea, there's muscle myalgia. Now if complications start occurring, we call that as complicated malaria. So anemia will be there. Then there can be acidosis, lactic acidosis. There can be cerebral malaria. There can be hemoglobinuria, which is black water fever. There can be hemoglobinuria. There can be non-cardiogenic pulmonary edema. This can lead to convulsions, seizures. So any of this is happening, it's complicated malaria. Coming to how do we manage a case of malaria. So investigations we are doing the investigation of choice, which is a thick blood smear. So there are two kinds of blood smear, thick and thin. This is done to know what species it is. species it is, and this is done to know if the parasite is present or not. This is not preferred because it is less sensitive. So the blood collection time is 2 hours after the peak of febrile period. This is when we collect the blood and we make a smear. Few things about the smear. This is the slide. The smear should be something like this. Covers the 3/4 of the slide, does not touch the edges, feathered margins, a single uniform smear which is thin, so thin that the underlying, if there's a newspaper under it, it can be seen. Only one layer of RBCs are there, just to know what is a good slide. We stain this with Giemsa staining, and we see it under light microscopy. So certain features of parasites can be seen. So we have vivax, falciparum, ovale, and malaria. Here we see ring forms, the early trophozoids. We see ring forms. In vivax only a single ring form is there. Here multiple ring forms will be there, and there will be double dot forms also, and this one is called an acole form. Here also ring forms are seen, same as vivax. Now late trophozoid. Here we see this. Here we cannot see it. Here there is a fimbriated RBC, and then the gametocyte. Here we see multiple almost covers it. Here's only 3/4 of the RBC is covered with it. Here a fimbricated RBC will be there, covering 3/4 of the RBC by the gametocyte. So this is blood staining. Now second is we have other modalities. So we can do QBC. QBC is quantitative puffy coat examination. So a capillary tube is there where it is coated with acridin orange from the inside. This stains the DNA very brilliantly. Normal RBCs do not have any DNA. If there is an infected RBC, it has the parasite, DNA will be there and it will be stained. So we take a blood sample in this tube and we centrifuge it, and then we examine under UV light. Other can be immunofluorescence. So we just same blood slide, we stain it with acridin orange and we see under immunofluorescence. So all this is very cumbersome. In the peripheries it cannot be done, so we have the rapid diagnostic test. This is based on detecting the antigen of the parasite. So we have parasitic Plasmodium LDH. This is for all the species. If it's Plasmodium falciparum LDH, then it is specific. This antigen is specific for falciparum. Then we have the histidine rich protein 2. This is also specific for falciparum. Then we have the Plasmodium aldolase. This can also be detected. Now coming to the treatment. So treatment is divided into 4: uncomplicated and complicated. So for uncomplicated, we have Vivax, and we have for falciparum or mixed infections. So here Vivax we give chloroquine plus primaquine. Primaquine is given to prevent recurrence. This Vivax and Ovel shows recurrence, and this falciparum shows recrudescence. Recurrence is basically even after completion of theory, the patient will be completely alright, everything will be normal, no signs, no symptoms, and they are not even detected by clinical tests, so they go to a very subclinical level and they remain in the hepatocytes in the form of hypnozoids, and later on they can recur again and cause malaria. Recrudescence is the phenomena where even after completing the theory, even after completing the treatment, the plasmodium parasite is still detected in the blood. So chloroquine plus primaquine, here the dose is 0.25 mg per kg once daily for 14 days. Chloroquine we give 25 mg total. So day 1, day 2 and day 3, 10 mg, 10 mg and 5 mg. This is per kg. Okay, this is for Vivax. If there's mixed infection, the drug of choice is artemisinin combination therapy. This regimen is given by the government. There is no variation in this. There are two things: artemisinin combination therapy (SP). This is for sulfadoxine pyrimethamine, and artemisinin combination therapy AL. This is lumefantrine and artemether. So here we give artesunate, sulfadoxine pyrimethamine, and pyrimethamine, and primaquine is given everywhere. So this is given famously called 80 by 480. So we give 80 mg BD for 3 days, which comes out to be total 480 mg. Artesunate, this is given in northeast states. This is everywhere other the northeast states. In India we can give this. We give this. So artesunate is given, sulfadoxine is given, pyrimethamine is given, and both the regimens we give primaquine 0.75 mg per kg single dose on day 2. Here also we give primaquine in the same way. Primaquine is basically given to prevent recurrence. Now if it is complicated malaria, usually cerebral malaria, we give artesunate. So if we take one dose as 2.4 mg per kg on day 1, one stat dose is given, then at 12 hours we give one dose, then at 24 hours we give one dose, on day 2 we give one dose, day 3 we give one dose. This is IV therapy, and all these drugs are oral. Now a few other things. Primaquine cannot be given in pregnancy, but in pregnancy to infants and to G6PD deficient people. In pregnancy, in trimester 1 we give quinidine, trimester 2 and 3 artemisinin combination therapy can be given. And coming to prophylaxis, so if it's less than 6 weeks or more than 6 weeks, this is for travelers anywhere. If somebody is traveling for more than 6 weeks, so we give doxy 100 mg for since 2 days before the trip till 4 weeks after. Here we give mefloquine, same 2 days before the trip till 4 weeks after, and that's it.